A very good morning to everyone. Hope I'm audible, sir.
Yes.
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 It's indeed a great pleasure and honor to have with us today Professor Brian Weinschenker. He's a professor of neurology at Mayo Clinic with special interest on various CNS demyelinating disorders. He has many awards and honors to his credit. Outstanding one is the John Distel Prize in 2011 from the American Academy of Neurology and National MS Society. So if we see here, he's in the international recommendations for almost all CNS demyelination, MS, NMO, and recently on MOG. So it's quite apt that we hear on NMO spectrum disorders from Professor Brian. Over to you, Professor.
Thank you. Thank you very much for the kind introduction, and it's nice to be back with you at this very unusual and difficult time in the world. And I hope all of you are staying safe and finding that you're able to care for patients as well as possible under the circumstances. Well, I'm going to speak to you today about neuromyelitis optica spectrum disorders, which is certainly one of my favorite subjects to speak about. And we're going to cover mainly diagnosis and pathophysiology tonight. We're not going to really talk about treatment unless any questions come up at the end. And what I'm going to do is begin by reviewing for you the history of the development of the current concept of neuromyelitis optica spectrum disorder, which, if I look back 20 years ago, I would say that many neurologists would have argued that it might not exist as an independent disease entity, that it couldn't really be differentiated from multiple sclerosis, but really there's no doubt about it. And it's not only an academic issue, but we've learned that patients with neuromyelitis optica spectrum disorder often do not respond or may actually be harmed by many of the treatments that we use for multiple sclerosis. So it is a very practical and clinically important issue. But I think in order to understand the spectrum of this disease, having a reasonable understanding of the history of it, it would be worthwhile. We'll then talk about the clinical manifestations, which, as I'll tell you, have extended well beyond optic neuritis and myelitis, which are the prototypic syndromes of this condition, although those are certainly still the most important and frequent syndromes. There are many others that, and many other ways that neuromyelitis optica can present. And I think it is important that we be aware of these other kinds of presentations to avoid missing this important diagnosis. And we'll talk about the diagnosis and some clinical pearls about making a diagnosis in this condition. And then we'll talk about pathogenesis and etiology, and I'll hint about how the understanding the pathogenesis has suggested some new treatments, and I'll mention that some of these treatments have now been established to be highly effective in phase 3 clinical trials. So let's go to the historical perspective, and I'm going to do this with one slide and tell you 3 parallel stories. So the first story, I'm going to begin with De Vick in 1894. Actually, that's probably not exactly the place where I should start. And one of my colleagues in Heidelberg, Germany, Sven Jarius, who's a student of the history of neuromyelitis optica, has written some very nice papers in the Journal of Neuroinflammation. And he's reviewed many reports of optic neuritis and myelitis that were probably the same disease that were referred to by a number of different terms. A fairly common term that was used in the 19th century was spinal amaurosis. But the report that got the most attention was that of De Vick. In fact, the Turkish neurologists later on referred to it as de Vic's disease, and that's really how it was best known throughout the 20th century. But de Vic described a single case, a young woman who developed bilateral optic neuritis in quick succession and myelitis and died within several months. And his student wrote a thesis and reviewed the world literature, which consisted of 16 additional cases. And really, de Vic had not proposed any diagnostic criteria for this condition, but he said this is something really different than multiple sclerosis. But really did not have many answers. But throughout the next 90 years, rather than trying to figure out what this disease was, I think most people tried to understand de Vic's case and figure out what was unique about de Vic's case. And they said, well, de Vic's case didn't relapse. I suspect de Vic would have said, how could this patient have relapsed? Because she died. But by convention, this diagnosis was only made in patients who had a monophasic illness and did not relapse and had optic neuritis. Many clinicians felt it could only be diagnosed if it occurred, like de Vic's patient, in both eyes, and had myelitis within quick succession. And in fact, it was said, and there was a French neurologist called Van Bogert, who was quite well known, who wrote that if the patient had relapses, it showed you made a diagnostic error, because by convention, any relapsing CNS disease was considered multiple sclerosis. In the 1990s, several groups from Queen Square and our group at Mayo Clinic, I would say, were leaders, looked more broadly and developed clinical, radiologic, and laboratory criteria. A review of large series, we reviewed just over 70 patients at Mayo Clinic and came up with the first diagnostic criteria published in 1999. And we claimed that we could differentiate neuromyelitis optica and multiple sclerosis. But we said that it didn't seem to be essential that patients had bilateral optic neuritis. Unilateral optic neuritis was sufficient. And unlike what was the convention and dogma at the time, that this was a non-relapsing disease, we found that the vast majority of patients who fit our criteria did experience relapses. And this was similar to conclusions reached by a group at Queen Square, O'Riordan et al. I collaborated with Dr. Vanda Lennon, a neuroimmunologist at Mayo Clinic, and she was particularly interested in these patients because one thing we had recognized in 1990 is there was a very high frequency of other autoimmune diseases in these patients. And Dr. Lennon was a believer that multiple sclerosis was not really an autoimmune disease, but she thought what I was talking about, this neuromyelitis optica, might well be a classic autoimmune disease. And she used similar technology that she used to detect cancer-related autoimmune CNS disease or paraneoplastic diseases, looking for antibody binding in these patients' sera on a substrate of rodent tissues. And she discovered this pattern of staining. And we reported this in 2004 that seemed to be specific for neuromyelitis optica. And using the criteria that we developed in 1999 and published, there seemed to be a perfect association between this immunofluorescence pattern and a diagnosis of neuromyelitis optica, and this was never seen in patients with multiple sclerosis. 1 year later, Dr. Lennon, through a variety of techniques, immunoprecipitation, using a knockout animal for aquaporin 4, she was able to show that the target antigen was aquaporin 4. And you know, it was a very interesting story how she figured this out. She and other members of her lab I think they were greatly aided by the fact that they were able to detect binding of this antibody, not only in the brain tissue, but also in the kidneys, in the medulla of the kidney. And they inferred that the antigen was likely aquaporin 4. And then, as I mentioned, went about proving this through a variety of ways. And in a definitive publication in the Journal of Experimental Medicine in 2005, confirmed that the target protein of this autoantibody was aquaporin 4, a water channel in the brain. And using that antibody, we were first able to show that this was highly, highly specific. And then using that very highly specific antibody, we found that in fact, this antibody was present in patients who had certain clinical syndromes that extended beyond optic neuritis and myelitis, included patients who had syndromes such as intractable vomiting and hiccups, included patients with various brain lesions. So it became clear to us, initially we thought, well, maybe these are false positives, but it became very clear that those patients had a predominance of optic neuritis and myelitis. And we now recognize an extended spectrum of syndromes that are associated with aquaporin 4 antibodies that are now known as the NMO spectrum of disorders, or NMOSD. The second story occurs in Asia, and specifically in Japan. And prior to 1960, it was thought that multiple sclerosis was very rare in Japan. There was little known about it. And several authors started to study MS occurring in Japan, Okanaka and Kuroiwa, and they actually held a symposium and wrote a monograph about MS in Asia and in Japan. And they said there were really two forms. There was Western MS, or classical MS, and there was a Japanese or Asian type of MS, which was very remarkably isolated to the optic nerves and spinal cord and tended to relapse. And I think really in retrospect, our Japanese colleagues were well ahead of the West in recognizing that this was a distinct form of relapsing disease. In 1996, Kira really articulated the clinical aspect of opticospinal MS. He did allow for minor brainstem involvement, and interestingly, we certainly recognize a number of brainstem syndromes in patients with neuromyelitis optica, but he said there could not be any cerebellar or cerebral lesions, and he also recognized this as a relapsing disease. In 2004, coincident with the work that we were doing at Mayo Clinic, I visited Japan and was keen to see a number of patients with optic spinal MS. And it struck me that those patients were really very similar to the patients that I was seeing in the West. And then in collaboration with my host in Japan, Professor Kazuo Fujihara, we began to test sera in a collaborative way that he sent to us blinded. Some were from classical Western MS, some were from Japanese opticospinal MS. Professor Fujihara was particularly interested at the clinical differences between those patients, so he was really a perfect collaborator. And in fact, we found that there was perfect segregation with testing that Dr. Lennon did of the sera and those patients who were positive for aquaporin 4 antibody, and with the optic spinal form of MS, as opposed to the Western or classical MS in Japan. And so now, in general, it's accepted that what had been called pure opticospinal MS is in general the same as neuromyelitis optica spectrum disorder with aquaporin 4 antibodies. Well, we had known that not all patients with clinical neuromyelitis optica spectrum disorder, those who satisfied the criteria, Not all were seropositive for aquaporin 4 antibodies. There were about 20 to 30% who were seronegative. And here we have our next story. And our next story actually starts in France in the mid-1980s. Labar et al., using an antibody, a rodent antibody, were able to isolate and identify a minor myelin protein that they called M2 on the surface of the myelin sheath. Almost in parallel work with a rodent antibody by Chris Linnington, who collaborated with Hans Lassmann. They were able to show that this antibody was able to produce extensive demyelination in animals that had EAE, or actually even those without EAE. Systemic administration of this antibody produced extensive demyelination in the brain. Typically with EAE, one sees perivascular inflammation, but not extensive confluent demyelination, but infusion of this antibody resulted in this kind of extensive demyelination. So it was recognized that antibodies that were reactive to this M2 protein, or what was called MOG, myelin oligodendrocyte glycoprotein, this minor myelin protein on the surface of the myelin sheath, was capable of producing demyelination. In 1996, Hartmut Weckerle from Germany and Vijay Kutchru from Harvard developed a double knock-in mouse with both the T cell receptor and immunoglobulin that reacted to myelin oligodendrocyte glycoprotein. And they reported that a very high percentage of these double transgenic mice had a spontaneous phenotype that looked a lot like neuromyelitis optica, with prominent optic nerve and spinal cord involvement. People suggested that this might be a model for neuromyelitis optica, but in fact, these mice, these double transgenic mice, did not have antibodies to aquaporin 4. And so the significance wasn't immediately clear. At that time, there was a lot of interest in the importance of anti-MOG antibodies in multiple sclerosis, and there was a New England Journal of Medicine paper published by Thomas Berger from Austria, reporting that the detection of MOG antibodies was able to predict those individuals who converted from clinically isolated demyelinating syndrome to multiple sclerosis. However, in trying to replicate those studies on a number of other data sets, it became clear that this was not correct. And essentially, this story has been debunked. And I would say it really caused, unfortunately, some delay in interest in MOG antibodies. People somehow lost interest. But in that study that was reported in 2003, the antibodies were detected by Western blot. And using new conformational appropriate assays where the MOG proteins were expressed on the surface of cells, so-called cell-based assays, the antibodies were detected, and it became clear, work done in Austria, especially by Marcus Reindl, that these antibodies were complement activating, and they were detected mainly in patients with neuromyelitis optica, not in patients with MS. This has been confirmed by multiple groups in the UK, Japan, and Germany. And now it is widely accepted that somewhere between 20 and 50%, it depends on the part of the world that you look. In Brazil, it's more like 20%. In the UK, more like 50% of the aquaporin 4 seronegative NMOSD. So it's going to be about 15% of overall NMOSD are seropositive for MOG antibodies. Turns out, and I understand you've had a lecture from Professor Anu Jacob who no doubt told you that many patients with MOG antibodies have other conditions, including encephalitis, acute disseminated encephalomyelitis. So unlike the aquaporin 4 antibodies, which really are very, very typical and specific for neuromyelitis optica spectrum disorder, but it's important to know that in that group of seronegative, the 30% seronegative, somewhere between 20 and 50% seem to have MOG antibodies. So that's my overview of the history of neuromyelitis optica. Let's talk about the diagnosis. And, you know, after I started to see these patients and we came up with diagnostic criteria in 1999, my sense was, this is easy. If you just know these basic rules, it's usually not hard to distinguish these patients. Neuromyelitis optica was optic neuritis, typically severe, often extending back to the chiasm. Here's a patient with a swollen gadolinium-enhancing optic chiasm, or longitudinally extensive myelitis, which doesn't look at all like MS, where we see small peripheral lesions. You see these long, extensive spinal cord lesions. We used greater than 3 vertebral segments as a cutoff, sometimes extend up into the medulla. And if you find this, optic neuritis and myelitis together, you got a diagnosis. And that seemed rather straightforward. There were usually no other clinical manifestations. The brain MRI, especially at presentation, was usually normal or nonspecific, quite different than MS, where typically we would see these ovoid lesions in a periventricular distribution. Usually there were no oligoclonal bands. We had to know that the disease usually relapsed, and most had this specific biomarker. Things improved. Initially, we were finding only 40–50% who were seropositive, but now with the better, more sensitive and specific assays, about 70% are seropositive for aquaporin 4 antibodies. So really, NMOSD diagnosis, I thought, was usually easy. But then we started to get these reports about patients with intractable nausea and vomiting, where they have cancer associated, that they have myositis, hydrocephalus, association with NMDA encephalitis, even cutaneous manifestations, associations with Aicardi-Gouttiere syndrome, or seen with biotinidase deficiency. And all of a sudden, what seemed to be a very straightforward, easy story became extremely complex and chaotic. So why can it sometimes be hard to diagnose NMOSD? Because number one, it may not cause both optic neuritis and myelitis. An important proportion of the patients have recurrent optic neuritis or recurrent myelitis alone and not both. The clinical features are more heterogeneous. You can have patients with brain syndromes, but typically not ones that are seen in MS. So things like hypothalamic lesions with narcolepsy, or thalamic lesions with anorexia or other eating disorders, or SIADH, things that we don't see in MS. Big, large tumefactive lesions, or large, longitudinally extensive corpus callosum lesions with encephalopathy. We've learned that about 15% of the patients who have myelitis may not reach that threshold of 3 vertebral segment length lesion, although usually the lesions will be in the center of the spinal cord rather than peripheral, and they're usually longer than the average MS lesion. Some will have brain lesions, and initially, when people saw brain lesions in patients with NMO, they said, well, they have both MS and NMO. We've learned that there are some lesions fairly specific for NMOSD, but there are patients who are very tricky and may have lesions that may look somewhat like MS. So there is no single criterion that absolutely distinguishes NMO, excuse me, NMO from MS. And aquaporin 4 antibodies are not present in about 30% of cases. And depending on the assay that one uses, but a very common assay used in commercial tests in the United States is called ELISA, can be associated with an important proportion of false positives, which is very dependent on the pretest probability. If you're testing a very typical NMO patient, there's going to be few false positives. But if the majority of patients that you're testing don't have NMO, if you're working in a low pretest probability situation, it turns out that the majority of positive tests are actually false positive. And in situations in the United States where we see a very high proportion of patients with all demyelinating disease having this test, if one is looking at an ELISA test, there's a high rate of false positives, which should be confirmed with a cell-based assay. Some patients have this MOG-associated disease that has somewhat different clinical manifestations, as we'll talk about. And a very important source of confusion are comorbid illnesses. So the two are particularly autoimmune disease, by far the most common, and the odd person who may have cancer. But if the autoimmune disease is myasthenia gravis and they have myasthenia gravis and then optic neuritis and myelitis, people have no problem with that. They say, well, a patient has myasthenia gravis and they've got NMO. But when the autoimmune disease is, as we'll talk about, NMDA receptor encephalitis, and you have this patient who comes in with encephalopathy and dyskinesias and then gets optic neuritis and myelitis, it seems like a crazy situation. And what's the differential here with all these different manifestations? It's important to realize that some of these diseases occur together more frequently than can be expected. And you have two conditions, NMDA receptor encephalitis and aquaporin 4 IgG associated NMO, and they can occur contemporaneously. So that can be a very confusing situation that you should be aware of. And occasionally we'll just find incidental occurrence of two different pathologies, and it may not be NMO at all. We may have a patient with a different kind of myelitis, and then they get ischemic optic neuritis, and people will say, well, this is NMO, but it may be two distinct kinds of pathologies. Now, we certainly have Occam's razor, and we don't think first that these are two different pathologies, but in fact, these things can happen. So I'm going to classify patients in a way that hopefully will bring some order to the chaos. I think the first thing to think of is it aquaporin 4 or MOG? And if it's aquaporin 4, is it a direct attack due to aquaporin 4 antibodies, which typically affect optic nerve, spinal cord, or the dorsal medulla, producing the so-called AP syndrome, area postrema syndrome, with intractable vomiting or hiccups? Is it a syndrome affecting some other part of the CNS, the brainstem, circumventricular organs, or supratentorial, producing one of those syndromes like narcolepsy or eating disorder? Or rarely, you can have patients with neuromyelitis optica who have extra CNS involvement, and the one that's been best recognized is myositis. Another not common thing is indirect manifestations, not due to a direct complement activation, but an indirect complication. And the one that I'm referring to that occurs is hydrocephalus. And this is typically because of periependymal inflammation that results in aqueductal stenosis. And I'll show you a few of those cases in a minute. Then we have the MOG syndrome, which very much overlaps with aquaporin 4, but we'll talk about how you distinguish those in a minute. Although I understand you've heard of this, you've heard this from Professor Jacob. I won't talk about it at too much length. Occasionally, we'll see patients with intractable disease who are older and don't respond very well to treatment, have aquaporin 4 antibodies. In that situation, it's worth considering whether they might have a cancer which expresses aquaporin 4. And this has been seen with a variety of cancers. And typically it's suspected when the patient's older and has intractable symptoms. It seems like in this situation, area postrema syndrome with intractable vomiting and hiccups is particularly common. We've talked about the comorbidities and especially coexisting autoimmune disease, which can be a CNS autoimmune disease or a systemic autoimmune disease, such as lupus. And many patients have been diagnosed with lupus myelitis, where basically they have comorbid lupus and neuromyelitis optica spectrum disorder. In fact, I would say the majority of patients who have lupus and then develop myelitis, if you test them for aquaporin 4 antibodies, you will find those antibodies. So it's not the lupus causing the myelitis, it's just that those two conditions occur together more frequently than expected. And occasionally they may be totally different diseases like sarcoidosis, which can cause both optic neuritis and myelitis, cancer, and even certain metabolic disorders. One is biotinidase deficiency, a rare condition. I've not actually seen one myself, but there have been several reports in the literature of how this can closely mimic neuromyelitis optica spectrum disorder. So I'm going to use a series of Venn diagrams to illustrate this. And I find this, if you try to memorize just the appearance of this Venn diagram, it keeps this straight. So if you have a patient with optic neuritis and myelitis, you're thinking of, is it aquaporin 4, MOG, or MS? How do you figure this out? Partly based on demographics. What's unique for aquaporin 4 is the very prominent female predominance. Of course, we see excess of women in multiple sclerosis, not so much in MOG. And if you have a patient who has other autoimmune disease, that's another big clue. We aren't really sure, I think, of the predilection or of the racial predilection of MOG disease, but aquaporin 4 disease does have some predilection for non-Caucasians. So seeing a non-Caucasian with optic neuritis, I think one should be particularly suspicious about aquaporin 4 disease. Optic neuritis appears somewhat clinically different. With MOG disease, it's often bilateral, and there's often fairly prominent papillitis. And that's probably because it tends to be so anterior. With aquaporin 4, it tends to be more posterior, involving the chiasm. Both of these are situations where the optic nerve is involved over a long segment, whereas with MS, tends more often to be affected over a short segment. With myelitis, tends to be more severe with aquaporin 4. The entire cord tends to be swollen. There's more prominent enhancement. With MOG, there may be less gadolinium enhancement or no gadolinium enhancement. And it's particularly helpful if you see involvement of the conus and the caudal spinal cord. This is very typical for MOG. Certainly anywhere in the spinal cord could be affected with MOG, but there is, of those cases that have involvement of the conus, I think that's a clue for MOG disease. Whereas with MS, we almost never see long spinal cord lesions. Practically always, the lesions are no more than 2 vertebral segments in length. Area postrema syndrome, it's been said that it can also occur with MOG, but in our experience, very rare with MOG, whereas it occurs in about 20% often the very first symptom in patients with aquaporin 4. As far as the course, both aquaporin 4, well, all of them relapse. Probably the relapse frequency is highest for aquaporin 4, especially if it's untreated. The relapses in terms of severity and recovery are worse with aquaporin 4. And I think that is a helpful point. What about extraspinal syndromes? There are many. The most common is intractable vomiting and hiccup, but hearing loss, hypogeusia has been reported, pruritus, trigeminal neuralgia, brain syndromes. Probably the most commonest are hypothalamic and thalamic syndromes, but encephalopathy, tumefactive lesions can occur, endocrinopathies, and we'll talk in a minute about myositis. This is a study of 258 patients who had brainstem manifestations, which occurred in a third of the patients reported in this series, and the most frequent one was vomiting and hiccups, followed fairly closely by oculomotor dysfunction and pruritus, whereas hearing loss, facial palsy, ataxia, trigeminal neuralgia were quite rare. This was a report of a patient from our center who had multiple episodes of myalgias, often associated with very prominent elevations of CK. You can see as high as 63,000, some episodes not so high, and ultimately had a muscle biopsy, which showed perivascular inflammation. And when the muscle biopsy was stained for aquaporin 4, there was complete loss of staining for aquaporin 4, very reminiscent for what we see in lesions in the brain and optic nerve, where there's widespread loss of aquaporin 4 staining. Whereas in other inflammatory myopathies like dermatomyositis, there is preservation of aquaporin 4 staining. So this is not just a manifestation of destructive muscle disease or an inflammatory muscle disease. Here's a normal control muscle where you can see this staining in the membrane for aquaporin 4. With this aquaporin 4 myopathy, the patient does get fairly widespread loss of aquaporin 4 staining. I mentioned hydrocephalus, and approximately 1% of seropositive cases in this series from Mayo Clinic as well had evidence of aqueductal stenosis and hydrocephalus. So if a patient with neuromyelitis optica develops symptoms of hydrocephalus, it probably is due to neuromyelitis optica. What about comorbid illnesses? The most important one is autoimmunity, and many different kinds of autoimmunity have been reported. Most common is thyroid, but next to that, lupus and Sjogren's, but IgG4's disease has been reported, Crohn's disease, limbic encephalitis and NMDA receptor encephalitis. And the other important comorbidity is cancer. And I mentioned that about 3% of cases, neuromyelitis optica with aquaporin 4 antibodies, especially in older patients with a more severe course and intractable to treatment, have associated cancers. So might be worth looking for a cancer with a PET scan in that kind of situation. Other things that have been reported are other diseases that are associated with disturbed immunity. Cutaneous manifestations most commonly are those that have been associated with connective tissue disease like scleroderma and conditions like that. Xerosis of the skin can also occur, especially in patients who have quite severe pruritus. This was a nice series, a very large experience. Of course, this is Joseph Dalmau and Martin Titulaire who have a huge experience with NMDA receptor encephalitis. And they reported some years ago in the Annals of Neurology that 23 of 691 patients with NMDA receptor encephalitis had either clinical or MRI manifestations of demyelinating disease. And when they tested those patients for serologic evidence of either aquaporin 4 or MOG-associated diseases, about half of them were positive. Whereas in the patients who had NMDA receptor encephalitis disease without these manifestations of optic neuritis or myelitis, hardly ever were these patients positive. So it didn't seem that these were false positives. These were clinically important associations. And although it's a relatively small percentage, it's again an indication that these conditions can be comorbid. And we've certainly seen very similar things and studied the same manifestation in patients who have lupus or Sjogren's, who develop optic neuritis and myelitis. Most of those patients have aquaporin 4 antibodies. And finally, we come to the mimics, things that are not neuromyelitis optica, but can cause optic neuritis and myelitis and can lead to diagnostic confusion. And I won't have time to talk about many of them. Among the ones are sarcoidosis, I'll talk about that. GFAP encephalitis can cause myelopathy, but hardly ever anything that looks like an acute myelitis. So it's not really much of a mimic, but certainly with the long lesion in the spinal cord that can occur with GFAP encephalomyelitis, someone who's not familiar might become confused. Certain paraneoplastic diseases, such as associated with CRIMP5 antibodies, can be associated with both optic neuritis and myelitis. And there are genetic disorders I've mentioned: biotinidase deficiency, adrenomyeloneuropathy, and hereditary spastic paraplegia, which hardly ever has T2 signal abnormality within the spinal cord. It's more of a chronic myelopathy. And I think when one is aware of the fact that neuromyelitis optica practically always causes acute attacks of myelitis, it isn't really a serious differential diagnosis, but again, a source of confusion. Sarcoidosis definitely can be a source of confusion. And in fact, we thought it would be worthwhile, and we published this in 2016, to look at 71 patients, 37 who were aquaporin 4 IgG seropositive, and 34 who had spinal cord sarcoidosis. In half of the cases, they were misdiagnosed as NMO spectrum disorder. We found a number of things could help differentiate them, not just radiology, although I believe radiology is probably the most helpful. Among the characteristics we saw in the patients with NMO is practically always the myelopathy was very acute and developed in days, over days. Women were predominant. As we know, 90% of cases with aquaporin 4 disease are women. A number of them had concurrent optic neuritis or history of nausea and vomiting, whereas the spinal cord sarcoidosis patients, usually the myelopathy evolved over months rather than over days. But there was overlap. We did see some patients with spinal sarcoidosis whose syndrome seemed to develop over a number of days. More commonly, they had constitutional symptoms, but far from always. In many patients, we could detect hyaluradenopathy, or if we did a CT scan of the chest, but certainly not in many of the patients, probably not even in half the patients. And often there was CSF pleocytosis, and in about 20 to 30%, the CSF glucose was somewhat lower than 50% of the simultaneous serum glucose. But what we found was most helpful was the radiology. Now, if you look at the T2 images, as here A1, B1, C1, really, it wouldn't be possible to distinguish this from what I showed you in neuromyelitis optica. But when we looked at the pattern of gadolinium enhancement, I think this is a particularly good example here in B3. We saw this very characteristic dorsal subpeel enhancement. This is shown very well here as well in C2. The dorsal subpeel enhancement, we see it here too. And on the axial images, again, the axial T2 is not very specific, but with gadolinium, we see what we call the trident sign. Again, this dorsal subpeel enhancement and often enhancement of the central canal. And we said, this looks like a trident. And when we sent it in, the reviewers said, no, we don't see this as a trident. So we drew a trident beside, and then they said, yes, okay, that seems to be right. But that dorsal subpeel enhancement sign. So what clues would I give you for making sure the diagnosis of NMOSD is correct? First, require objective findings. Because there can be false positive serology, I would always say avoid diagnoses exclusively based on serology. There should be compatible clinical and radiologic findings, but be aware that there are also atypical findings, including things like short spinal cord lesions. Don't discard the diagnosis when the presentation is atypical. I've mentioned some of the rare presentations, and be aware of the fact that having lupus does not exclude it. Because if you have lupus, it doesn't mean that this is lupus myelitis. You could have lupus and NMO at the same time. If you're unsure about the serology and it's an atypical clinical presentation, always worthwhile getting a cell binding assay to confirm it. If the and I would say working with a lab where you have a fair degree of confidence is going to be important. Ask yourself whether the MRI features are highly suggestive. An isolated hypothalamic lesion with no other brain lesion, highly suggestive. Is it compatible, or are there red flags like ovoid lesions by the temporal horn? That's very suggestive of MS. If you see that, you should really think twice about this diagnosis of NMO. Recognize that some patients with MS will have optic neuritis and myelitis. Their brain MRI initially may be fairly normal. That doesn't make a diagnosis of NMOSD. And one other very common problem we see is in patients with primary progressive MS who have a conglomeration of many smaller lesions in the spinal cord. It may look like a so-called LETM, but the clinical history is not acute myelitis. It's chronic myelopathy. That's another situation that you should be very careful about. If there are oligoclonal bands in the spinal fluid, that can occur in 20% of patients with NMO, but it is a red flag. And think twice about that diagnosis. If the course is progressive from onset, that's a big red flag. That is something that hardly ever would we see in NMO, which practically always causes acute relapses of myelitis. If there's no response to steroids, well, that can occur in NMO, but is somewhat atypical. If you see a patient that you've got on rituximab and azathioprine, they're still having relapses or progression, again, atypical. Consider other pathologies. If you've got something like the dorsal subpeel enhancement or trident sign, think of something like sarcoid. Okay, so to summarize the first part of the talk, the longer part of the talk, optic neuritis and myelitis, think of NMO versus MS or aquaporin 4 versus MOG. Think about whether this is a direct manifestation or an indirect manifestation like hydrocephalus. If it's direct, it can involve extra optic nerve and spinal structures like the area postrema, circumventricular organs, corpus callosum. Think about the two important comorbid illnesses, autoimmune disease and cancer, or could this be a mimic? So I think if you remember this diagram, some of that confusion that I showed in the slide before where it seemed like NMO has become total chaos might make some sense. So let's turn to the pathophysiology. And really the pathophysiology as we understand it now is, in a sense, fairly simple. And normally, or 10 years ago, I might have started with aquaporin 4 antibodies, which seem to be the main effector of pathology in neuromyelitis optica, but we know it's an IgG1 antibody, and it is dependent on T cell help. And so we think there's got to be some place where an aquaporin 4 peptide in the context of a class 2 MHC molecule is presented to a naive T cell, generates an immune response. And we know that in NMO, based on the cytokine profile, on the kind of pathology we see with prominent neutrophils, that NMO appears to be predominantly a Th17 disease. And that's another difference from multiple sclerosis. We're hopeful that at some point, and we'll talk about immune tolerance, and I'll tell you that we've learned that there are defects in immune tolerance in NMO, that we might be able to develop strategies to promote immune tolerance. And maybe ultimately will allow us to get patients off immunosuppressive treatments. But these T cells facilitate B cell recognition in the periphery of conformationally intact aquaporin 4 antigens, which is what stimulate B cell receptors to activate B cells. And then that promotes differentiation into plasmablasts. And we've learned that there are important trophic functions like IL-6, which is also very much involved in Th17 cell polarization. But there's very good evidence both in serum and spinal fluid during attacks that IL-6 levels are grossly elevated in neuromyelitis optica. And here we use immunosuppression, which has been the treatments we've used for many years, like azathioprine and mycophenolate and corticosteroids. But now we have successful results of 2 different clinical trials of a drug called sartrilizumab, which is very similar to tocilizumab. This drug has not yet been approved by regulators, but it's widely anticipated that this might occur in the next year, which blocks the effect of IL-6 on its receptor, probably important also at the level of T cells, and also acts at the blood-brain barrier. Here's what has become the mainstay of treatment in the West, B-cell monoclonal antibodies. And we have new antibodies that are directed to CD19, which, so we have this drug inabilizumab, which was also the subject of a phase 3 clinical trial and is widely anticipated to be approved in the next year, not approved yet. The product of these mature plasma cells and plasmablasts are aquaporin 4 antibodies, which of course circulates systemically, and we have plasma exchange that we use primarily in acute situations to remove those antibodies, a very effective form of treatment in steroid refractory patients. These antibodies get through a breach in the blood-brain barrier, which may be the area postrema in the medulla where the blood-brain barrier is relatively deficient, or the circumventricular organs, but can be other parts of the central nervous system. And they immediately encounter their target antigen, aquaporin 4, which is transported down astrocytes to these astrocyte foot processes. And there are 2 different isoforms of aquaporin 4, M1 and M23. We'll talk about this a little later. And they aggregate, especially if there's high levels of expression of M23, which is 22 amino acids shorter than M1. They're both encoded on the same gene, but these 2 different isoforms are produced. And where there's a lot of M23, it favors the production of these large supramolecular aggregates, which actually had been recognized by freeze fracture electron microscopy as these big aggregate particles that it really wasn't clear what they were from, but as soon as aquaporin 4s were found and aquaporin 4 was knocked out, these supramolecular aggregates disappeared. But that conformation in aggregates seems to favor the binding of these antibodies in green and activation of complement. There is interest in blocking or developing antibodies that bind to aquaporin 4 that are engineered so that they don't activate complement and don't attract natural killer cells. The one antibody that's being developed is called aquaporimab. This is still in development, but a very interesting antigen-specific treatment. And then complement is activated, which seems to be very critical to the pathology, and a variety of complement inhibitors. Most importantly, eculizumab, which is being regulator approved, the first FDA and also EMA and Japanese drug agency approved treatment for neuromyelitis optica, acts at the level of complement, and it actually blocks the C5 protein. And we know that complement activation leads to chemotaxis of a variety of granulocytes like neutrophils and eosinophils, and at least experimentally, and these have actually been studied in phase 1 clinical trials, but there seems to be promise that blocking these products of neutrophils and eosinophils can be effective. And finally, there are other types of things that occur when aquaporin 4 binds to, or where aquaporin 4 IgG binds to its target. Aquaporin 4 is physically linked to excitatory amino acid transporter 2 and becomes internalized along with this transporter protein, which is involved in deactivating glutamate and transporting or promoting reuptake of glutamate. So the consequence is increased glutamate levels, and glutamate is excitotoxic, and that might be a contributor as well. Furthermore, we know that from work done at Mayo Clinic, binding of this antibody to aquaporin 4 acts as a danger signal and activates intracellular transcription of a variety of cascades of cytokines, especially the NF-kappa B pathway, leading to elevated levels of TNF-alpha. So that's an overview and gives you some idea of how we've been able to rationally choose products that might be effective. And in fact, they have been confirmed in clinical trials. I'll talk about two at the end of this talk now, talk about two other questions that I think we've reached some answers and provide us further questions about why people get NMO and why the optic nerve and spinal cord are affected. So I'll begin with DeVick's riddle. He wrote, why this particular localization? What is the intimate nature of this process? He was wise, he didn't speculate. He said one can do no more than propose hypotheses, and I will abstain from discussing it. But what have we learned because of discovering the target antigen that might provide us some answers as to why the optic nerve and spinal cord are particularly affected? Well, aquaporin 4 is encoded on chromosome 18. As I mentioned, it's transcribed into two different proteins, M1 and M23, that differ just by this 22 amino acid N-terminus. And these get transported down the astrocyte to the astrocyte foot process, where they're complexed with dystrophin. And where there are mainly M1 isoforms, they tend to form these these tetramers, which is the basic unit of assembly. But where there's a lot of M23, perhaps because of not having the intracellular effect of this long extra tail, you get these complexes, which are mainly M23, and they tend to be decorated at their periphery with M1, which blocks the enlargement, further enlargement. So one of the theories was maybe people with neuromyelitis optica form very large assemblies which facilitate the binding of aquaporin 4 antibodies. And maybe that's why they're prone to getting this disease. And as I mentioned, and this is looking from the top down, here are the aquaporin 4 molecules, and you can see that having them in these tight aggregates that occurs on the astrocyte foot process facilitates the binding of C1q complement. So some years ago, I think this was 2013, when I still had an active lab, we did what seemed to be very obvious and look at optic nerve, spinal cord, and other parts of the brain and other tissues. And we did this in rodents, we did it in mice, rats, and we also did it in human subjects, healthy human controlled subjects, where we obtained tissue at autopsy. And we studied the expression of aquaporin 4, and where possible, both the individual isoforms M1 and M23. And we did this by looking at RNA expression with quantitative PCR. We used Western blot to look at proteins, and we also used a specific technique to look at the size of the supramolecular aggregates that we knew were present of aquaporin 4. And this next slide summarizes the key results from our paper that was published in JAMA Neurology. And I showed the relative expression using two different techniques, using ABI primers and cyber green. They differed in the absolute numbers that they got, but the relative expression is the same. And you can see that in spinal cord and optic nerve, compared to liver, kidney cortex, kidney medulla, brainstem, frontal lobe, the levels of expression of aquaporin 4 mRNA were far greater in optic nerve and spinal cord than those other tissues. Here is a Western blot, and we compared the immune staining by Western blot to staining for a control protein, beta-actin. So we loaded and stained for beta-actin and aquaporin 4. And you can see how little protein we loaded in the spinal cord and optic nerves. Look how little of the control protein there is. And of course, we did this so that we could interpret. Otherwise, if we loaded the same amount of protein as in the frontal lobe, we would have had a big black blob there. And so you can see we differentiated the M1 and M23. Here's the control M1 and M23 isoforms. And what we show here is semi-quantitative densitometry, which again shows that at a protein level, the expression of aquaporin 4 is far greater in the optic nerve and spinal cord. And using a technique, non-denaturing technique, using a detergent mixture that didn't fully denature the aquaporin 4, we were able to look at the size of the aggregates. Here's the optic nerve, here's the frontal lobe, here's the spinal cord. And you can see, especially in the optic nerve, a much higher number of these larger aggregates than you would find in the brain. So there was a greater proportion of protein that was in supramolecular aggregates in the optic nerve and spinal cord as well relative to brain. So does this tell us why patients developed NMO? And it doesn't. There was no difference in aquaporin 4 expression between cases and controls. And I don't think that should be a surprise, because the people who get NMO are patients who have this antibody. Patients who don't get NMO don't have this antibody. But it does help tell us why the optic nerve and spinal cord are especially prone because of that expression. There is some excess familial occurrence. We did a lot of work on sequencing aquaporin 4 gene, and we found no evidence for a structural defect in aquaporin 4. We've learned that HLA is associated, unlike MS, where we see a strong association with DR2. It's the most strongly associated gene. It's actually DR3 that is associated with NMO. In fact, DR2 is inversely associated with NMO. There's actually a lower frequency of DR2 in NMO patients, again speaking to the difference between this disease and multiple sclerosis. We believe that the aquaporin 4 antibodies are antigen driven. And I've talked about paraneoplastic NMO. There's been some interest in homologies between Clostridium perfringens and aquaporin 4, and whether that drives the production of this autoantibody. But another very key question that I'll talk about in the next slide that I think is a very important aspect of NMO, which hadn't really been understood, I think, until the last year or so, is why do patients with NMO have a general immunodysregulation with predisposition to many other autoimmune disease? And this was a paper that was published 2019, so just last year, by Kevin O'Connor at Yale University and a number of his colleagues, which I think is a very elegant paper. And Kevin is interested in many aspects of B cell dysregulation. And he had an assay that was able to isolate B cells at various points in differentiation. B cells undergo differentiation in the bone marrow, then come out into the periphery. And there are mechanisms, just like there are in the thymus, for deletion of autoreactive clones in the bone marrow and also in the periphery. So he was able to isolate those various ones and express these recombinant antibodies made by those B cells and study them for autoreactivity and polyreactivity. And he had these assays to study those. And in particular, he studied 6 human anti-aquaporin 4 antibodies by reverting the B cells that were producing them back to their unmutated germline precursors, because there are these somatic mutations which result in the antigen maturation. And when he did that, as would be expected, those antibodies didn't react any longer to aquaporin 4 because it is these somatic mutations that are necessary, that are antigen driven, that are necessary to generate aquaporin 4 antibodies. But what he found is when he reverted these cells back to their germline precursors, the antibodies that they were producing were polyreactive. So he suggested that there were both central and peripheral tolerance defects. They weren't specific for NMO. He found the same thing in myasthenia gravis and lupus. Somatic mutation was necessary for aquaporin 4 IgG production, but aquaporin 4 IgG production just didn't occur randomly in any old B cell. It occurred in this pool of autoreactive and polyreactive B cells that were cells that had escaped central tolerance. So he has a very nice diagram illustrating this concept. So under healthy circumstance, you're born with a certain number of autoreactive cells that get counter-selected in the bone marrow, exit to the periphery, and then there's further counter-selection by a variety of immune mechanisms, anergy and B cell regulatory cells, so that in the end, we have very few autoreactive cells. With NMOSD, there seems to be a defect both centrally and peripherally, resulting in excess numbers of these autoreactive and polyreactive abnormal cells that are then driven by antigen expression, wherever that expression occurs, in a paraneoplastic context or molecular mimicry from bacteria, that really isn't defined, to these aquaporin 4 autoantibody producing cells. But it seems like you need both problems, that being driven there by the antigen, but starting out with these polyreactive, autoreactive cells that have escaped central and peripheral tolerance mechanisms. So my final slide, my conclusions about pathogenesis. Aquaporin 4 antibodies are an antigen-driven process leading to the production of IgG1 antibodies that are directed to aquaporin 4. But there are probably central and peripheral tolerance defects leading to these abnormal poly and autoreactive B cells, and this may explain the predisposition to multiple autoimmune diseases. And finally, that expression of aquaporin 4 is particularly high in the optic nerve and spinal cord by orders of magnitude greater than in other parts of the brain and other tissues, which may explain in part the exquisite sensitivity of the optic nerve and spinal cord to aquaporin 4 antibodies, but there don't seem to be any important differences in expression of aquaporin 4 between individuals that have this disease and don't have the disease. The reason people get this disease is because they get this antibody, not because they abnormally express aquaporin 4. So those are some insights that I can give you on the pathogenesis, and I think I'll stop there, and I hope I haven't talked too long. I'm happy to answer any questions that you may have.
Thank you, Brian. That was a masterful lecture. Didn't know there's so much going on in NMO and so many new concepts. I think it's going to take some time to sink in what all you have told us. So I'll ask Dr. Netravati and Sripad to ask what questions there are. I have a number of questions, but first let us take the audience question. Dr. Netravati, Sripad?
Yeah.
Netravati, would you like to begin with the questions? And you can go halfway through and then I can catch up.
Yes, sure.
Begin. Yeah.
So there are around 20 questions from the audience. The first one was, patient with optic neuritis or long segment myelitis whose serum NMO is negative, but CSF NMO is positive. Should we treat this patient in line of NMO spectrum?
This would be a very unusual situation because in the vast majority of patients, the serum will be more sensitive than the spinal fluid. Now, I think occasionally this can come up, and we did have this issue come up in a number of patients before, that because there may be multiple autoantibodies in the serum and things would be messy, and especially when we were testing with immunofluorescence, we would get this messy pattern and we couldn't call the antibody, and then the CSF was cleaner and the pattern of immunofluorescence would be much easier to detect. But with the current cell-based assays, that would be a very unusual circumstance. So if they have a very convincing clinical circumstance, and if there's a believable pattern either in CSF or serum, I guess I would be very suspicious about neuromyelitis optica, but that would be, I would probably send off the serum to another lab and see if it comes back positive. But probably that would be neuromyelitis optica.
Professor Brian, can this happen that with plasmapheresis, this type of scenario can happen, or what is your observation about this discrepancy between serum and CSF NMO?
Well, certainly if you test a patient after they've had plasma exchange, they may be falsely negative. And yeah, probably the CSF antibodies wouldn't be removed as well. So I think that would be a very credible explanation. Yes.
Okay, the second question is from Dr. Kalpana Vijay, who says, can there be both aquaporin and MOG positivity? And what do you do in such conditions?
You know, in most of the studies where that's being studied, it doesn't occur. Uh, I don't think I've ever faced that circumstance, and I've spoken with other experts who are quite interested in MOG testing, and they say they virtually never see it. Never say never. Anything can happen, but I think it would be a very unusual circumstance.
So actually we do
Do you see MS with NMO
MS.
simultaneously? Because MS is more common than MOG. So can the two happen just by chance?
Theoretically, they should occur. I think we'd always be a little reluctant to make a diagnosis of MS if we really think it's NMO, because um, I would say, and my rule of thumb is if you really don't know, and occasionally that comes up, and often it's because the data aren't there. Patient had a history of myelitis, they didn't have an MRI, so you're seeing it. You do an MRI now, you don't see a long lesion, but maybe that's just because you haven't got the imaging during the acute myelitis. If it really sounds like NMO, severe myelitis, and but they've got some lesions that maybe could look like MS, I would treat them with rituximab, which should work for both. I think it's an unusual situation where we can't tell the difference, but that does come up.
There's one more question. Dr. Vikas, do we first treat the first episode of long segment myelitis with negative NMO antibody with immunosuppressant? I think what he wants to ask is, you have a long segment myelitis, but your NMO is negative. So do you treat such patients with immunosuppressant?
No, I don't. I think there are some people with idiopathic transverse myelitis, and we did a study where we looked prospectively at a large series. It was published in the Annals of Neurology in 2006, if I recall. And, you know, we found that none of the patients who were seronegative for aquaporin 4 antibodies had relapses over, it was like a mean follow-up of 1.5 years, if I remember. Whereas we found 50% of those who had aquaporin 4 positive. Now, if they relapse and they get a second episode, I would treat them, regardless of their serology. But after a first episode, a very high percentage of those patients, if they're seronegative, I would say the vast majority probably will not relapse.
But if your first episode, you have a high clinical suspicion of NMO, what would you do? After stopping steroids, would you repeat the
Why
antibodies?
would you have a high clinical suspicion?
Like involvement of area postrema or the cervicomedullary junction. And in such cases, would you repeat the NMO antibodies after a duration of illness?
Well, maybe that might be a circumstance, but I would say in general, acute idiopathic transverse myelitis, differentiating that from an attack of aquaporin 4, if their serology is negative, it's really very hard to do so. Zoster myelitis can look very much, you know, of course, there's usually a history of zoster, but the lesion clinically and MRI can look just like aquaporin 4. And I think if the serology is negative, after a first episode, I'd be reluctant to put somebody on long-term immunosuppression. I don't know what the endpoint would be. Whereas if they're positive, I think they should be treated.
And if you have started them on immunosuppressants and they're almost relapse-free for a longer duration, say 2 years or 3 years. So when would you take a decision about stopping the immunosuppressants?
Well, I think if you're pretty convinced that they are NMO, even if they've had a single attack but they're aquaporin 4 seropositive, my inclination would be never to stop, because I don't think you can safely do so, and the risk of a relapse can be pretty bad. I've seen a number of patients who have stopped their treatment for a variety of reasons. Often they've decided to do it, and they've been stable for a number of years. They get worried about the risks of treatment, and then they get a terrible attack. So just too risky to do it, in my opinion. And I think most experts agree with that.
Brian, more of your patients are on rituximab or on azathioprine? And in the long run, if you have to give for life, which one would you prefer?
I have many patients who I've had on azathioprine for many years, and I've seen no need to stop it. I generally, if anything is going well, I don't instantly switch to the latest treatments. These days, I would say most patients generally choose to get rituximab. There are a lot of advantages. It's once every 6 months. It's pretty well tolerated. It's more specific, and if you accept the head-to-head comparative studies, there are some retrospective ones. Seems like it's somewhat more effective. I think that is controversial, and maybe that's not absolutely true. I think both are fairly well tolerated, but rituximab is relatively more specific. So I'd probably be inclined to use rituximab. How the new drugs are going to influence what we do, we don't yet know the cost of all of them, but eculizumab is $500,000 a year, so it's really almost prohibitive. Unless the patient really has failed other treatments.
When somebody's on lifelong immunosuppression, with azathioprine, we see our patients sometimes get tuberculosis or some infection like that, but not had much of a problem with rituximab. Do you also feel the same long-term?
We get very little trouble, and PML, which we tend to worry about, is about 1 in 10,000 based on the rheumatoid arthritis experience. But what about COVID? I mean, that's obviously a concern, and if we want to vaccinate patients, we try to vaccinate them before we start them on treatment. But if we get a good vaccine for COVID, are they going to respond? And there have been now some patients who have developed, MS patients on ocrelizumab who've developed COVID. I don't think we have any good conclusions, as we were discussing before, yet. But I know Genentech is monitoring this quite closely and giving us feedback on what their experience is. So hopefully we'll get a clearer answer about what the risks are in this new era.
In India, the cost is actually quite good because we have generic rituximab, so it works out to almost $500 every 6 months. It's quite cheap.
That's great.
Professor Brian, we have not had much of infectious complications, but I've had few patients who have developed urticaria. And what is your observation when they're on long-term rituximab? Apart from infections, any other autoimmunity have you observed?
That I'd attribute to rituximab, do you mean?
I don't know, it was just a chance coincidence, but at least more than 10 patients of mine who are on rituximab had developed urticaria after 1 to 2 years of taking rituximab.
With NMO?
Yes, with NMO.
Yeah, it's a tough thing with NMO when they get other autoimmune conditions. Is it because they have NMO and they're prone to autoimmune conditions, or is it because of the treatment? You know, you can get infusion reactions, acute infusion reactions with rituximab and urticaria. That's not so unusual. Chronic urticaria hasn't really been an issue that I've come across, but autoimmune conditions with NMO are fairly common. So I'm always thinking of that. If the patient develops something, could this be some other autoimmune condition that's comorbid with NMO? Because there are so many different ones. Professor Jacob, who I know wrote a very nice review and catalogs all the reports of autoimmunity, and there's like some 40 or 50 different autoimmune conditions that have been reported to occur. Almost everyone you can think of.
Brian, isn't rituximab second line or third line for most of the other autoimmune disorders also, and so should take care of that also? For example, if you have NMO with SLE, the rituximab should take care of both probably.
Theoretically, yes, as you say, that it's approved for many different autoimmune conditions, so it would probably be a pretty good treatment for some. We've had patients who are on different autoimmune treatments, Plaquenil and hydroxychloroquine, and you know, it's always a question: is that going to be adequate to cover this or that, or is rituximab going to be adequate? But as you say, you know, it's approved for rheumatoid arthritis and.
Absolutely.
Professor Sripath?
Yeah.
Yes.
You want
Shall I
to
carry on with a few questions?
Yeah.
Yeah. So there is a question, Dr. Weinschenker, in relation to hydrocephalus and myositis. When would you suspect NMO and send aquaporin in hydrocephalus and myositis?
Well, the typical situation with myositis is a patient with known NMO who gets myalgias with their attack. I've never heard of a patient who comes in just with myalgias and has a diagnosis of NMO made. I don't know of any distinctive characteristics, except that it tends not to be, you know, unlike dermatomyositis, a persistent myopathy, tends to be just attacks that occur along with optic neuritis and myelitis, which maybe that's somewhat distinctive.
Got it. And another similar question, I suppose, if a patient is positive for both NMO and NMDA, then what's your line of treatment? NMDA as well.
Yeah, that's a good question. You know, rituximab would probably be a pretty good treatment for both. Corticosteroids, plasma exchange.
Yeah,
It's
agreed.
effective for the NMDA receptor encephalitis.
Agreed. Intractable vomiting, the question is, does it respond well to steroids? I suppose the answer is yes. It's one of them which responds.
Yes, and it doesn't respond very well to just treatment for nausea. So variety of antiemetics, ondansetron and other potent antiemetics tend not to be very effective. So that I think should be a clue if you have a patient who's vomiting, they don't respond to these antiemetics. Usually there's no abdominal pain or other indicators of the GI disease. I mean, there are many other causes one has to think of. CNS diseases, even chest wall diseases can cause hiccups, but it's often vomiting and hiccups, intractable, but it very steroid responsive, usually within a day or two, much better with steroids.
Much better with steroids, absolutely. There is a very unique question here. A patient with long segment myelitis had positive TB PCR in his CSF and an aquaporin 4 antibody positive. Very difficult, I suppose.
What PCR?
But tuberculosis was positive in a segment myelitis, because we know that they can have the spinal arachnoiditis with signal in the cord and an aquaporin positive.
Yeah.
Very
Okay. And you know, there are of course some very interesting reports from Joseph Dalmau about patients who have HSV encephalitis, and then they get recurrent encephalitis, and people think right away, well, it's the HSV again. And in fact, they have NMDA receptor encephalitis. So it seems like sometimes these infectious conditions can lead to a secondary autoimmune encephalitis, and necessary to treat them for the autoimmune encephalitis. So I don't really have any experience with that HSV and aquaporin 4 or any other infectious, a TB and then aquaporin 4. But in the old literature, there was actually a lot written about the association with TB. Papers from South Africa years ago described NMO patients in association with tuberculosis. I really haven't seen much of that in my experience, but of course we see such little tuberculosis in the United States, but you know, maybe in places that have this, somehow that leads to a secondary autoimmune problem. It seems to be an interesting thing with COVID, and they get anti-cardiolipin antibodies and anti-endothelial reactions. So you have an infectious disease leading to an autoimmune cytokine storm with autoimmunity. So there may well be something there that needs to be better studied.
Link that needs to be studied, I agree. And in seronegative NMOSD, is the approach and treatment any different? And another question linked to that, after steroids, do all patients need to go on immunosuppression? I suppose it's yes.
Okay, we'll take the seronegative ones. It's a very complicated. The first question is, do they need to be treated? And you know, the experience had been that a number of these patients seem to go, even without treatment, be attack-free. Now I think we're recognizing a higher and higher percentage of them will relapse. It seems that those who remain persistently seropositive for MOG-IgG are the ones that are at greater risk, especially children, where we see more children with these MOG antibodies. A number of them will become seronegative, and they seem to be at lower risk. What the optimal treatment is, I don't think anybody really knows. Azathioprine is pretty widely used in the UK, where they have a lot of experience. IVIG, they say in children, that seems to work pretty well, but the data are weak.
And the other question, where after steroids, everybody goes on immunosuppression, correct? In relation
with aquaporin 4 disease?
Yes.
Well, you know, in Japan, they were managing a lot of patients with low-dose prednisone with apparent benefit. I think that's not happening so much anymore, and pretty much everybody gets put on a steroid-sparing drug or rituximab, which most people accept work better. But if, I suppose, a very helpful thing, if say a patient's on azathioprine and they get breakthrough disease, sometimes adding 10 milligrams per day of prednisone to their treatment can seem to help quite a bit. Now, again, there's not a lot of controlled experience, but that's been my clinical experience, and I've been told by many colleagues in Japan that this was an approach that was commonly used.
Absolutely. Professor Singhal is on the chat, and he compliments you for an excellent talk, and thanks you for the elaborate presentation. There's a question: the severity of disease, does it correlate with the titer of antibodies? Do we really see that way?
No, I would say, especially across patients, there doesn't seem to be any good correlation. In individual patients, there's, I would say, some correlation with titer and predisposition to attacks, that if the titers go way down, there's less attacks. If the titers go up, there's a higher risk of attacks. There was a study done recently in the UK, and actually I think they used data from the United States as well, trying to look at the predictive value of titer in terms of attack frequency, and it was not very good. So I think that's not going to be very promising. Something that does seem to be promising was presented in abstract form based on the inebilizumab study results, using the Samoa technique to detect glial fibrillary astrocyte protein, GFAP. And they found that at baseline in the study, when patients were enrolled, there were about 20–30% that had an elevated beyond 3 standard deviations from the mean serum GFAP using this Samoa method. And the frequency on study of getting attacks in those who had a high GFAP at baseline was quite a bit higher than the frequency in the other group. And during an attack, the levels went very, very high. This is being demonstrated in the CSF by Japanese colleagues about a decade ago. But now in the serum, using this Samoa technique, they were able to pick up very high levels of GFAP during attacks of optic neuritis and myelitis. And so that makes it, that would be such a convenient thing to be able to measure serum GFAP. They actually showed that the higher it was, the closer you were to an attack. Those who had an attack within a week had higher levels than those that were 2 months away from an attack. So wouldn't that be nice to be able to measure that on an ongoing basis and anticipate attacks and be able to intensify treatment and select patients for clinical trials who were going to have more events because their GFAP at baseline was elevated. This is not yet published. As I say, it was presented in abstract form at ECTRIMS in 2019.
Very good. And how often do one see conus lesions? Conus medullaris.
You know, mainly that's something that we see with this MOG disease. One thing about MOG is usually if myelitis occurs, it tends not to recur. That's been our experience. MOG disease mainly is optic neuritis. Myelitis you may see, but most patients don't have recurrent myelitis, unlike aquaportin 4 disease where that's not that unusual. But with MOG, I don't know what proportion have it in the conus. I would think it's probably the minority. But when it does occur in the conus, that is very, very characteristic for MOG.
And about the other aquaporins, apart from aquaporin 4, what is your comment on them, on pathogenesis?
You know, as far as we know, antibodies to other aquaporins are not pathogenic. At least this is my understanding. Why they really were proteins that, you know, you could knock out the animals. The animals survived pretty well. They were a little more prone to cytotoxic edema, but, you know, they were sort of proteins waiting for a disease to be discovered. And the first one turned out to be aquaportin 4. I don't think there's any convincing evidence of autoimmunity to aquaporin 1 through all the others, which are mainly systemic proteins.
Professor Singhal asks, how long to continue rituximab, and can after 4 years we switch over to azathioprine?
I think that is possible. I would ask, if the cost is not prohibitive, why one would do that. I don't think there's any compelling need to do so. And I've kept people on rituximab now for decades. I have a large number of patients who are on it for decades. We don't have very good data about the comparative efficacy, but what we've got seems to suggest rituximab is somewhat more effective.
Yes. He also asks, Professor also asks, if we have missed varicella vaccine before our first dose of rituximab, can we give it before the second one?
Yeah, I think if you're going to give vaccines, you want to give it as, just before the next dose, when the biologic effects start to wane, and B cells are recovering. Yes, I think that's probably what I would do, is give the vaccine. Ideally, give as many vaccines as you can before you start rituximab. But I think it is worth waiting until just before the next dose.
Actually,
I just want to
Netravati,
ask
you
one.
carry on.
Yeah, no, I just want to ask one thing on rituximab, because we were discussing now. So you told you have a long follow-up of nearly a decade of patients who are on rituximab. So do you monitor them on CD19 and then only give, or if they have completed almost 6 months and still CD19 is low? Sometimes even at the end of 9 months, 10 months, we see CD19 is low. So should we give rituximab during that time? What is your experience?
I would suggest you do, and I do. When I first started using rituximab, Bruce Cleve was the first one to report the effectiveness of rituximab from UCSF, and he taught me. He said, I just treat patients every 6 months. It's probably before you need to treat them, but I don't want them to get anywhere close to getting recovery of B cells. And if you're treating enough patients, unless you're very, very good at being able to keep up on all of this and call them in, and I think it's just risky that their B cells will start to recover, because as I mentioned, I've found that, you'll find they're 0 and then they come up to 1-2%, and the next month they're up to 10%, and then they have an attack. So since we're not dealing with dose-related toxicity, this is a highly specific agent that just depletes B cells, and we want to keep the B cells fully depleted. The easiest thing is not to test, just treat everybody within 6 months. And in 95% plus of patients, that they should not have started to repopulate by then. When I do test it is if they have a relapse, because at that point I want to know if this is because they've been an early repopulator. So I think that's the time to test, but I don't bother testing most people.
Thank you.
Do you want to finish?
No, sir, you continue, sir. You continue.
Okay. So, Professor, actually unrelated to the aquaporin 4, but there is a question on MOG. First attack of edema or optic neuritis with MOG, would you immunosuppress?
No, I probably wouldn't in that situation, because I think the ones that have ADEM and have MOG, often the MOG is transient. Maybe it's even a reaction rather than primarily pathogenic. So I think most would suggest follow along the MOG titers, and at 6 months, if the MOG titer was still positive, maybe that would be the right thing to do, but the evidence is weak.
I suppose the last question, your experience with tocilizumab, and where do you place it in the armamentarium?
Well, the agent that probably will be approved in the next year, at least I think it will be sartolizumab, which is very similar to tocilizumab, but has been engineered so that it undergoes pH-dependent dissociation in the cell, and it gets re-secreted and is still active. So it gives, in a sense, more activity. Looked very good in the clinical trials. Maybe looked a little less good because there were a third of the patients who were aquaporin 4 seronegative, and the benefits in now both of the studies that have been done with sartolizumab, the Sakura Sky study was published in the New England Journal of Medicine just a week ago. The Sakura Star, which is the treatment placebo-controlled monotherapy study where there was no background immunosuppression in any of the patients, was published in Lancet Neurology. And if you look at the aquaporin 4 positive group, they're in the range of over 70% reduction in relapses. So I think, another very potent drug. You might look at it and say, well, eculizumab was over 90%, but there are important differences in the definition of attack, in how long the studies were conducted, other things that I think it does make it a little difficult to compare across. Sartolizumab is a subcutaneous medication that patients self-administer, which compared to, say, eculizumab, which is intravenous every 2 weeks and have to go in for infusions. We don't know what the cost will be for sartolizumab, but it does seem like a highly potent drug that I think would, and there is phase 3 data. Having said that, I always tend to go with things that I've got a lot of experience with. Now, rituximab is not an officially approved drug, but I've been using it for a long time. I think it is highly effective. And I doubt very much I'm going to take patients who are stable on rituximab for many years off that drug and say, well, we got to switch you to one of the new ones. But it's nice to have it as a backup.
Absolutely, absolutely. I suppose the last question now: do aquaporin 4 antibodies ever become negative?
Patients, yes, they do. I would say in a minority of patients, but some patients on treatment will become seronegative, especially rituximab. This has been reported for quite some time. I think the assays have become more sensitive. It happens less often now. It's usually good news if they do become seronegative. There have been a number of studies that reported that patients who became seronegative did much better than those that didn't, which isn't surprising because we think it's a direct pathogenic antibody. But yeah, and certainly if they do become seronegative, I would be very reluctant to say, okay, they're seronegative, it's safe to stop. Once seropositive, confidently, they're always seropositive, and they'd be at risk if you stop treatment.
I think that's all for the questions. I think we've had such a great session today with so many points covered. Fantastic one. Netravati, do you want to say something?
I think it has been very nice. Many people would correlate just having some of the core clinical features with NMO. I think it was very lucid talk where you made us aware that it is not just optic neuritis and myelitis, and the pathogenesis was very well covered. Thanks a lot, Professor Brian.
Thank you very much. Thank you. Dr. Kothari?
Thank you for asking me.
Thank you, Brian. That really was a fantastic talk. I mean, the way you covered clinical features, going from basic things to unusual presentations to the mimics to overlap and amazing. I mean, we want to hear. I'll talk to you later, but I want to hear only a talk on pathophysiology sometime, explaining how that whole cascade goes. It's quite something.
Absolutely.
Just now, I think we let you sleep. Thank you. That was really a beautiful lecture. Thank you, Dr. Netravati. Thank you, Shripad.
Thank you.
Thank you, sir.
Thank
Thank
you.
you very much. Thank you.
Thank you.
Thank
Good night.
you.
Bye.
Bye.